Perinatal means around the time of birth. So natal is giving birth, peri, around, and this is a time period that encompasses the entirety of pregnancy and also the first year postpartum. And I'm going to talk about mental health instead of depression because a lot of people tend to think of depression as the primary or maybe the only disorder that individuals might experience after the birth of a child. But it turns out that there's a pretty wide range of emotional experiences that are really common during both pregnancy and the first year after a child is born. So these include depression. They also include the anxiety disorders. So we see an increase in anxiety associated with depression and also primary anxiety disorders. We also see a really interesting increase in obsessive thoughts and compulsive behaviors. We see those in normal populations, but we also see an increase in clinical disorder, OCD, during the perinatal period. And we can also see disorders like PTSD. So for example, women who experience traumatic childbirth or parents whose children are in the NICU might experience symptoms of PTSD related to that trauma. And there's also a much more rare disorder called postpartum psychosis that affects about 1 in 1,000 women after the birth of a child. So it's very rare, but it's a pretty serious disorder. And sometimes people confuse that with postpartum depression. So I think it is kind of more accurate to talk about perinatal mental health and the wide variety of problems we might see rather than focusing on postpartum depression, which is probably the best known of the disorders. The risk factors for perinatal mental health disorders are pretty similar to what we see in the general population. They include demographic risk factors, things like low socioeconomic status, interpersonal risk factors, so low social support is a particularly strong risk factor, and for women who are in relationships, relationship dissatisfaction or conflict in that relationship. And we also have some cognitive risk factors, so some general cognitive biases, things like perfectionism or attributional style, and also some specific beliefs related to motherhood. So for example, women who have beliefs about kind of maternal over responsibility, things like I'm the only person who can keep my baby safe, or beliefs that other people might judge them if they observe negative behaviors. So people see my baby crying, they're gonna think that I'm a bad mother. All of these are risk factors for perinatal depression and anxiety. There is some evidence that there may be a subset of women who are particularly vulnerable to depression and other symptoms during periods of hormonal transition. So for them, the hormonal transition that accompanies pregnancy and delivery might be a particular risk factor. So these include women with a history of depression or other symptoms related to other reproductive transitions. So for example, during puberty, or women who have premenstrual dysphoric disorder are at increased risk for perinatal depression, and also a family history, both of depression and anxiety, but particularly for perinatal episodes. So there's increased risk for perinatal disorders among women who have a first-degree relative, particularly a mother or a sister who had a perinatal episode. One of the really great things about treatment for perinatal mental disorders is that there's a really wide range of effective treatments. So it means that we can tailor the treatments that we're choosing in terms of what a woman prefers, and also to address some of the logistical hurdles that she might be facing in terms of accessing treatment. So the treatments for perinatal mental health, pretty much similar to the effective treatments that we see for these disorders in the general population. So if we're talking about depression, antidepressants are effective, and many of them are safe for use during pregnancy and by breastfeeding women. Many women have concerns about medication safety during pregnancy and while they're breastfeeding, so they may be more interested in using non-pharmacological treatment options. We have biological treatment options that are not medication. So for example, repetitive transcranial magnetic stimulation, or RTMS, has been found to be effective and safe for use by pregnant women. So that can be an option, particularly for women with severe or treatment-resistant depression. And we've also got a really wide range of effective psychotherapy. So these include interpersonal psychotherapy. There's a little bit of evidence suggesting that IPT might be more effective than other kinds of psychotherapy for perinatal depression compared to other empirically supported treatments for depression. But there's also good evidence that cognitive behavioral therapy is an effective treatment for perinatal depression. And another really good thing about these treatments is that we've got evidence that they can be adapted to make them more accessible. So for example, internet-based interventions, which can be really helpful, not only in contexts like we have now, where we have limitations on people coming to face-to-face treatments, but for women who already have either a lot of medical appointments during pregnancy, when towards the late end of pregnancy, women will often be seeing their doctors once a week or maybe more, so they may not have time, they may not be able to get out of work to go to many appointments. Or after their baby is born, it can just be really hard to get out of the door and to manage scheduling. So internet-based treatments are effective and can be a really nice option. And group interventions are also effective. And one thing that they can be really great for is addressing that lack of social support that's often a risk factor for depression and anxiety. Providing that community and helping normalize their experiences can be a really great part of treatment. So there's a really wide range of effective treatments, which means that there are lots of options for helping women get better. So fathers also experience perinatal mental health problems. Interestingly, compared to women, there is more evidence for increased risk for depression during pregnancy in the first year postpartum for fathers compared to mothers. So the rates are lower for fathers, but because women in general have a higher prevalence of depression compared to men, the increased risk with pregnancy and the birth of a child is actually greater for men compared to women. The risk factors are pretty similar. Interestingly, one of the stronger risk factors for paternal depression is maternal depression. So a lot of people are starting to think of this not necessarily as an individual disorder, but really as a disorder that affects the whole family constellation. So if anyone in this family is experiencing distress, it's going to affect a parent, it's going to affect their co-parent, and it's also going to affect both parents' relationships with the infant. So we can really think of this from a family systems perspective. With fathers, there has been less research on risk factors and on treatment. One of the things that we know is that fathers are really interested in having interventions and having treatments that specifically address their needs. And these range from preventive programs. So for example, in childbirth education classes, having information that is specific to fathers and their roles rather than focusing on fathers in a support role for the mother or as a parent to the child. And also for specifically addressing fathers' needs when it comes to things like depression and anxiety and considering some of the things that might influence their experience. Things like gender roles and expectations. If they have a partner who is experiencing depression, balancing their desire and their need to provide support for their partner with addressing their own mental health needs and getting the support that they need. So this is a really important area and an area with lots of growing research. Perinatal depression and anxiety can have really important long-term consequences, not just for mom, but also for growing fetus, for the baby, and for the entire family constellation. So depression during pregnancy is associated with increased risk for negative birth outcomes. So moms who are depressed during pregnancy are more likely to give birth preterm. They're more likely to give birth to smaller babies, even if you control for gestational age. It's also a risk factor for preeclampsia, which is one of the leading causes of preterm labor. And the only effective treatment for preeclampsia is for the woman to deliver the baby. So this is a really important complication that can develop during pregnancy. So we can see adverse effects on fetal development after the baby is born. Depression can affect mom's parenting behaviors and her relationship with her infant. She might be less responsive. She might experience more distress in relation to kind of normative infant experiences. Infants of depressed moms can have more difficulty sleeping. That can sometimes be kind of a chicken or an egg problem. Is mom's depression kind of leading to a more unsettled infant with sleep problems? Or are you more likely to become depressed if you have a baby who's a bad sleeper? So a lot of these look like they are really kind of reciprocal dyadic processes. And we know that long-term outcomes for children of depressed mothers, we see increased risk for emotional and behavioral difficulties in children when we're looking at childhood, at adolescence, and also when we follow all the way through these individuals' own adulthoods. We can see increased risk for externalizing problems, impaired cognitive development, particularly for boys, we tend to see this. So a pretty wide range of negative outcomes. We do know that the more quickly mom gets treated and the more effective that treatment is, we can limit these long-term developmental consequences. So there do seem to be some time periods in which children are more susceptible to these maternal symptoms, and the less time moms have these symptoms, the better. So that's one of the reasons that we really push for screening and effective treatment, is because the faster you identify it and the quicker that you get mom into helpful treatment, the better it's going to be for mom, baby, and the whole family.